People need hip replacements when they're having a lot of pain in the pelvic region of their body. Usually people have pain in the groin. That's where the hip pain comes from. A lot of people think their hip is on the outside out here, and that can be the sign of a different condition. But people that need a hip replacement, typically the pain is in the groin or kind of in the back. A lot of people will grab their hand, shape it like a C, and say, "Yeah, I have pain right here, all the way around." But if it's on the outside only, it could be something else. The first thing is to determine whether they should be having a hip replacement. You come in, you get x-rays, we identify, yeah, you have osteoarthritis of the hip. There are a few other things that we do hip replacements for, but the grand majority of hip replacements are done for osteoarthritis. And then it becomes a matter of symptoms. So if we can control your symptoms with medications, that's a great way to go. But if your symptoms are not controlled with the oral medications, we can do cortisone injections. Those are not as helpful as they are in the knee, typically, but it is an option. And then ultimately, when somebody is having enough symptoms to where they're not doing things they enjoy, they have a hard time doing their activities of daily living, it's time. The nice part, hip replacements are great. It's one of the most successful surgeries that orthopedic surgeons do. 90 to 95% of people have an excellent result at 1 year, meaning no pain whatsoever, and they're happy they had it done. A lot of patients tell me that they wish they had done it way earlier. There are a couple different approaches to the hip. The approach is how we get down to the hip joint. So there's the anterior approach, which is the front, and then there's a posterior approach, which is on the side, kind of in the back. I do both approaches depending on the patient. I prefer to do the anterior approach if I can. People historically have recovered a little bit quicker, but the way I do the posterior approach, people recover quickly as well, because I leave a muscle on that a lot of people detach, and that helps with the recovery. Hip replacements are a lot easier to recover from than a total knee replacement or total shoulder replacement. On average, people get back a lot quicker. To recover, the first week is rough. I mean, it hurts. We did a major surgery, so it's expected. Usually by the time I see patients at 2 weeks, some are using a walker, some are using a cane, some are using nothing. They're starting to see the light at the end of the tunnel and still having pain every day, but doing pretty dang good. Between 2 weeks and 2 months, usually people are back to all of their activities. They golfed before, they're back to golf. Still having pain every so often. By 2 months, I'm hoping they're getting to the point where they're mostly pain-free. And then at 1 year, hopefully you forgot you had to replace it. Whenever we're doing surgery, we are looking at a risk-benefit analysis. The big idea is to figure out whether the benefit outweighs the risk. Pain is the reason we do the surgery. What we have to do is determine whether the person's pain outweighs the risks. Now, the risks of with hip replacement, the biggest one is infection. That's the one that's most feared. It's not super common, but it does happen. There are 3 things that patients can do to decrease that risk. 1, if they smoke, we have them quit smoking. 2, if they have diabetes, we have them get their sugars under control, which would be an A1C below 7 is what I like, but if somebody has difficulty controlling their sugars, we could do it below 8, but I try to get them below 7. And then the last is if somebody has morbid obesity, which is defined as a BMI over 40, we try to get them to lose weight. Now, I know that's easier said than done, and it's really hard to exercise when your hip hurts. So we definitely look at the patient as a whole to determine whether the benefit outweighs the risks. Then there's a risk of dislocation where the hip could pop out of socket. The anterior approach has a lower dislocation rate. I'm not necessarily unique, but there's not a lot of surgeons that use robotics in total hip arthroplasty. And I'm one of the surgeons in the area that do that. It is helpful to place the cup specifically for that patient. So I get back x-rays that show whether somebody has a stiff spine. That's a risk factor for dislocation. And so we take and we plug that information into the robotics before we even start the procedure and know where their leg could impinge and cause their hip to pop out and dislocate. The robotics is very recreatable. It makes me very precise as a surgeon. I can get the cup right where it needs to be. And then there are other risks, such as damaging surrounding structures, nerves, arteries, veins, tendons, ligaments. Almost all patients will have numbness on the side of the hip after an anterior hip replacement or a posterior hip replacement. Usually that will go away. Sometimes it doesn't. Usually the numbness doesn't bother people. They'll feel it. They'll just be like, oh yeah, it doesn't quite feel the same on this part of the hip. For the most part, like I mentioned earlier, 95% of people that get hip replacements do great. They don't have a complication and they're super happy they had it done.